Chapter 41 covers disorders of endocrine control and also disorders of growth and metabolism. So there's really two sections to this presentation. One are the endocrine control, so things like Addison's disease, Cushing's, thyroid disorders, some of the pituitary stuff that we're going to cover in one portion of class. And then we're going to have an entirely separate class period to discuss the different types of diabetes, metabolic syndrome, and some of the complications. And so I'm going to record this as one long presentation, but I will note in the middle of it where you can stop prior to the endocrine class, and then where you can pick up prior to the class on diabetes. Okay, so we're going to start out with categories of disturbances of endocrine function. So these are just kind of the broad categories, and then we're going to get into some of the specific glands that we see these type of disturbances in. So the first one is hypofunction, meaning that whatever gland we're discussing, whether it's the adrenal glands, whether it's the thyroid gland, whatever it is underproducing the necessary hormone that it is intended to make. So different things can cause hypofunction. Some are congenital defects, meaning that someone is born with the absence of that particular gland or impaired development of the gland, or perhaps they lack an enzyme that's needed to synthesize a particular hormone. So there's some genetic mutation inborn that has caused alteration in the function of that gland and its production of hormone. Sometimes this is caused by disruption of blood flow to the gland itself, causing ischemia. Sometimes it's infection that causes underproduction of the gland or inflammation. Many of these are autoimmune responses. We're going to talk about some of the autoimmune disorders that cause the body to start destroying the tissues within those glands. And sometimes hypoproduction is caused by a neoplastic growth, so some sort of tumor within the gland itself or within the pituitary gland that reduces production of hormones. With some of our glands, we see an overall decline in function with aging. We're going to talk about this in particular with the thyroid gland, a very common gland that we start to see high levels of underproduction as people age. There are some drugs that cause atrophy of particular glands, and sometimes we see atrophy of glands really for unknown reasons. It just occurs. You can also have receptor defects where the gland itself is producing enough of the hormone, but there aren't enough receptors on the target organs to respond to those hormones. And the other broad category is hyperfunction, where we have excessive hormone production. So some particular causes here, sometimes we have excessive stimulation with hyperplasia of the endocrine gland itself. So we might have excessive stimulation because of excess production from the pituitary or the hypothalamus. There's something that's causing hyperproduction here. And sometimes we see that maybe we have a tumor of the pituitary gland that is forcing it to pump out maybe more thyroid stimulating or cortisol stimulating hormones that lead to that hypersecretion. And sometimes we have a hormone producing tumor of the gland itself that causes hypersecretion. We also break endocrine disorders into different categories. So primary, secondary, and tertiary disorders of endocrine function. And these are really related to the cascade of hormonal responses that are regulated through the hypothalamic pituitary target endocrine gland axis. So we've talked about this before, but we have a picture here. So we have the hypothalamus that signals the pituitary gland, and then the pituitary gland signals the target organs. And they do this via varying hormone secretion at each point of that axis. Okay, and so when we look at primary, secondary, or tertiary endocrine disorders, we're talking about where within this axis the abnormality lies. Okay. So when we start with primary disorders, these endocrine disorders originate in the target organ or target gland, responsible for producing the hormone. And so in this picture where we see the hypothalamus, the pituitary, and the adrenal gland itself producing cortisol, the primary disorder happens right here within the adrenal gland itself. So there's something going on with the adrenal gland, whether it is tumor, whether it's atrophy, whatever it is that's causing either hyper or hypo secretion of hormone right at the level of the gland. Okay. In secondary disorders, the target gland is normal. So in this case, this adrenal cortex is normal, no issue here. But its function is altered by defective levels of stimulating hormones or releasing factors from the pituitary system. So a secondary disorder is going to originate right here at the pituitary. Okay, and in this case, what we have is some sort of abnormal secretion of ACTH, which is the hormone secreted by the anterior pituitary that signals the adrenal cortex, either hypersecretion or hyposecretion, but the secondary disorder originates here. Okay. And the final is tertiary disorders. So these result from hypothalamic dysfunction. So both the pituitary and the target organ are understimulated if it's the case of hyposecretion. And so normally a hypothalamus would release gonadotrophic releasing hormone, or CRH. And if that isn't happening, then we're not stimulating the pituitary, and we're also not stimulating the adrenal cortex. So no ACTH release, no cortisol release, and it's a tertiary problem happening right here at the level of the hypothalamus. Okay. So we're going to start our discussion of some individual issues of endocrine dysfunction with hypopituitarism. And so that's underproduction of the hormones of the pituitary gland. Okay. And so some common causes of hypopituitarism, it might be tumors within the pituitary gland itself. They're usually adenomas. So those are benign tumors typically. This can also happen from surgery or radiation of the pituitary gland itself, or surgery or radiation near the pituitary gland. It can also happen due to infection that kind of destroys or damages the pituitary. We can see this happen from infarction or blood loss, or loss of blood flow or supply to the pituitary that causes ischemia and death of that tissue. There are some genetic diseases that can cause hypopituitarism, and it can also be caused by hypothalamic disorders. And so the pituitary gland itself starts to atrophy because we don't have stimulation from the hypothalamus because of hypothalamic disorders. So those are the main causes of hypopituitarism, or underproduction from the pituitary gland. And when we think about the pituitary gland, it has a lot of different functions, a lot of different hormones that it secretes, many of which are used to signal those end glands to produce specific hormones. So decreased secretion of pituitary hormones is associated with increased morbidity and mortality. It has a lot of different functions, and so when we lose that pituitary function, we lose a lot of endocrine function in turn. Again, we talked about the causes. They might be congenital, they might be acquired abnormalities. So if we look at this slide, we see that the anterior pituitary produces ACTH, which signals the adrenal glands to produce things like cortisol. It signals the thyroid gland via TSH. It signals the release of different sex steroids using luteinizing hormone and follicular stimulating hormone. And it also releases growth hormones. Okay, so lots of different functions of the pituitary that we lose if we have hypofunction. It also produces ADH. We're not going to talk about that too much in this unit. We'll talk about ADH later in some of the fluid and electrolyte kind of pieces. But there's kind of a very specific cascade of changes or issues or clinical manifestations that we see in our patients who are experiencing hypopituitarism. We actually have a mnemonic for it. It's called Go Look for the Adenoma, because if you remember back, adenomas are one of the potential causes of hypopituitarism. So what that stands for is GO is for G. So that stands for GH, which is our growth hormone. So secretion of growth hormone is typically seen for, GH secretion is typically the first thing to be lost in these patients, okay? Next, after that is luteinizing hormone. So next we lose this luteinizing hormone. So we have a resultant lack in sex hormone production. Then we lose follicular stimulating hormone. And what we see with that are things like infertility. TSH loss is usually next. So we get secondary hypothyroidism, which we'll talk about at length in this unit. And then we lose ACTH. It's usually the last one to become deficient, and that results in adrenal insufficiency. Okay. So the manifestations that we see with hypopituitarism, they're usually what we call insidious in onset. So no usual signs and symptoms early on. So this can go unnoticed for a pretty significant period of time, and the symptoms usually come on really relatively gradually. We can lose about 75% of the function of our pituitary gland before we see any clinical manifestations here at all. Um, Sometimes when we actually see hypopituitarism, it's because of a sudden onset of some acute and life-threatening symptoms. And that happens related to the loss of ACTH with significant adrenal insufficiency. So remembering back to the last slide, remember we had that cascade and that go look for the adenomas. Growth hormone is lost, luteinizing follicular stimulating hormone is lost, thyroid changes happen. But when we really start to see these manifestations, it might be when we have that final step of that loss of adrenal function that brings people in with maybe a life-threatening adrenal insufficiency crisis. And we'll talk later in Addison's disease about what that really looks like. But it's really the final kind of manifestation here. Some other general overall symptoms that people might notice, especially as they kind of start to lose those different functions of the pituitary gland, they may feel just overall chronically unfit and unwell. They may have weakness and fatigue. This can be related to loss of growth hormone. It can be related to loss of thyroid function, which increases metabolic drive. They may lose their appetite, especially as their metabolic rate drops. Sexual function is often impaired, really related to the loss of our things like luteinizing hormone. They may become cold intolerant. This is also related to loss of thyroid function. So just some general characteristics here. And just remembering again that because the pituitary has so many functions, we can see a really big and wide range of symptomatology with the loss of pituitary function. So you should already have kind of a general idea of a lot of the things that we can use to measure hypothalamic pituitary target cell hormones from chapter 40 in your study of that. So hopefully a lot of these things are terms and things that you already know. But we can measure things like serum cortisol levels, serum prolactin levels. We can measure serum thyroxine, so T3 and T4 and TSH. We can measure levels of testosterone and estrogen, luteinizing hormone and follicular stimulating hormone. We can measure growth hormone and its effect on insulin-like growth hormone. We sometimes look at serum and plasma and urine osmolality. Remembering that ACTH controls the release of cortisol from the adrenal gland. TSH controls the secretion of thyroid hormone from the thyroid gland. Luteinizing hormone regulates sex hormones in the ovaries and testes. And follicular stimulating hormone, or FSH, regulates fertility in the ovaries and testes. So I mention these because these are all different hormonal levels that you should be somewhat familiar with when we start talking about how we do different diagnostics and measurements within that HP axis, because with this conversation, what we'll get at is doing some of the distinguishing between whether or not deficits we're seeing are primary, secondary, or tertiary in nature. So just, again, a discussion of all of the different hormones that we can measure. All right. So we're going to start with a discussion of our different thyroid disorders, and we'll start with a general discussion of just the control of thyroid function in general, okay? So what you see here is TRH, which is thyrotropin releasing hormone, being released from the hypothalamus. So you have the hypothalamus kind of up here in the brain. It releases TRH, and that TRH stimulates our anterior pituitary gland right up here to release TSH, or thyroid stimulating hormone. TSH in turn from that pituitary gland stimulates the thyroid gland to secrete T3 and T4. T3 and T4 enter target cells to exert their hormonal control. And that is through things like increased metabolism, growth and development, and increased effect of different catecholamines. We are going to talk about all these effects at length momentarily, so just don't worry about those for now, okay? And so when we have this thyrotropin releasing hormone, there's often some signal, some environmental signal coming into the hypothalamus that says we need to release more TRH. One of the strongest stimuli for increased TRH release is cold exposure to increase metabolic rate. Other things that can cause the increased TRH release, things like emotional reactions, other environmental stressors, all can tell our hypothalamus to increase TRH release. Okay. The other thing to understand here is the negative feedback system that is at play in our control of thyroid function. So as levels of T3 and T4 hormone increase in the serum, those increased levels now provide a negative feedback mechanism to inhibit further production of both TSH at the level of the pituitary and TRH at the hypothalamic level. So essentially, these increased levels of T3, T4 provide this negative feedback that says, look, we have enough T3, T4, we've got enough stimulation of our metabolic system, you can reduce production of TSH and TRH, and then that will sort of shut off any increased production of T3, T4. So that's the normal control system of the thyroid gland itself, okay? Another important piece to understand is that when we release T3 and T4, the only hormone that can enter the cell and exert its effect are unbound forms of thyroid hormone, okay? And when we talk about thyroid hormone, some are bound to proteins and others are unbound. We have three major proteins circulating within the serum that can bind themselves to thyroid hormone. Okay? We have thyroid hormone binding globulin, TBH, that carries approximately 70% of the T4 and T3 within our serum. We have thyroxine binding prealbumin that binds to approximately 10% of our circulating T4 and a little less of our T3. And we also have albumin as a circulating protein, and that binds about 15% of circulating T3 and T4. So the majority of thyroid hormone in the body is bound, okay? But only the unbound hormone can enter the cell and exert its effect. So what's left over after the thyroid hormone binds itself to all these proteins is the thyroid hormone that can exert an effect. So very little when you think about it, right? But if you lose the binding capacity of any of these hormones, now what you have is more free and circulating thyroid hormone. So a number of disease conditions, a number of pharmacologic agents can reduce the amount of binding protein circulating in the plasma. Okay, so things like glucocorticoid medications, systemic diseases that cause loss of protein, like protein malnutrition, kidney diseases, liver cirrhosis, um, drugs like phenytoin, aspirins, diazepam, all of these things can affect the binding of thyroid hormones to normal concentrations. And what this does is, again, it increases the amount of free T3, T4. So you might see increased action of those thyroid hormones when you have reduction in these binding proteins by either disease states or different drug interactions. So what do the thyroid hormones do? What are the major functions of thyroid hormones? Well, the first and one of the most important functions is the increase in metabolism and the increase in protein synthesis. So those metabolic effects are to essentially when we release thyroid hormone, we're increasing our BMR or our basal metabolic rate. As our basal metabolic rate goes up, so does the use of both glucose, fat, and protein. So we mobilize lipids from adipose tissue. We break down cholesterol in the liver. We can break down muscle. Um, and we can increase the intestinal absorption of glucose. So all of those things, fat breakdown, muscle breakdown, increased glucose intake, all of these things act to increase the available supply of energy and nutrients to support this increase in basal metabolic rate. Okay. Within the cardiovascular system, we see both cardiovascular and respiratory effects when we release more thyroid hormone. So as thyroid hormone levels go up, we see a rise in oxygen consumption as our metabolic rate increases. We see vasodilation, so kind of opening up of the blood vessels. This is especially prominent at the level of the skin. When our metabolic rate goes up, our body is producing a lot more internal heat. And we need to regulate that because we like to keep a set point of heat within the body. So we need to somehow release some of that heat being generated by that increased metabolic rate. And so if the blood vessels at the level of the skin start to dilate and more blood is sort of shunted to the skin, we start to lose a lot more heat through the skin by that action. And that helps to regulate some of that internal heat being produced by that increased basal metabolic rate. So someone might appear kind of flushed, their skin might be kind of warm as that vasodilation happens. Other cardiovascular changes that we see an increase in circulating blood volume. We see an increase in cardiac output, so the amount of blood that the heart pumps. We see an increase in ventilation, so our respiratory rate increases and the depth of the respirations may increase. We see our heart rate go up and what we call contractility increases, meaning the heart itself beats harder in a more forceful manner. In the gastrointestinal system, as thyroid hormone secretion increases, we see an increase in gastrointestinal motility, meaning more peristaltic activity, meaning the GI tract is like moving faster. We see an increase in GI secretions. We see increase in appetite and food intake to help support all of that increase in metabolic rate. But despite that increased intake and appetite, as thyroid hormone function increases, we see weight loss because of the increase in metabolic rate. We're not compensating enough with increased appetite and intake to prevent weight loss. Neuromuscular effects. Increase in thyroid hormones causes more like vigorous muscle reactions, and we even see in some folks tremoring because of that. Increased thyroid hormones can cause things like nervousness and anxiety and sleep problems. There's also a strong interaction between thyroid hormones and the sympathetic nervous system. So a lot of the sympathetic nervous system signs and symptoms we see look very similar to those of increased thyroid function. And the final thing I'll mention for thyroid hormones is they have a significant influence of growth and development in children. We'll talk a little bit about congenital hypothyroidism, but thyroid hormones help with mental development and attainment of sexual maturity. So their absence can cause disorders of sexual function and of mental development. So how do we measure and diagnose thyroid disorders? Well, we can measure T3 and T4, so those hormones being released directly from the thyroid gland. And we can also measure TSH, that hormone being released at the level of the pituitary to signal the thyroid. So TSH levels are often used to differentiate between primary thyroid disorders, which originate in the thyroid gland, and secondary thyroid disorders, which originate at the pituitary gland. So T3 and T4 levels are typically low in primary hypothyroidism. However, we'd see an elevation in the TSH levels. Okay, so that's one way that we can make certain that we're looking at primary hypothyroidism if somebody has the signs and symptoms of that. I'm going to skip over resin uptake test. Let's talk a little bit about assessment of thyroid autoantibodies. Thyroid autoantibodies are used to determine if someone has an autoimmune disorder that's causing damage to the thyroid itself. So oftentimes with people with hypothyroid disease, we also look for thyroid autoantibodies. We're doing that to assess for different autoimmune destruction of the thyroid itself. Radioiodine uptake tests, those measure the ability of the thyroid gland to concentrate and retain iodine. There's a long discussion in your book about how iodine functions within the thyroid itself to produce thyroid hormones. I really don't need you to dig into that too deeply. Just know that there's a connection between iodine, iodide, and thyroid function. Okay. Thyroid scans can be used to detect things like thyroid nodules. They can look at some of the functional activity within the thyroid gland. Ultrasonography can be used to differentiate cystic from solid thyroid lesions. So if someone has, maybe on palpation, if someone has noted a lesion or a nodule within the thyroid itself, we could look at that via ultrasound. CTs and MRIs are used to demonstrate tracheal compression or impingement on other neighboring structures. So the thyroid gland lies right over the trachea. And so if we have someone with maybe a large goiter, which is an enlargement of the thyroid gland, or if they have significant nodules within the thyroid itself, we start to worry about the growth of that thyroid starting to press on the trachea or other kind of important structures in the area. So we can look at that via CT and MRI to just make sure we're not having any of that issue if the thyroid is becoming enlarged. And the final thing here is fine needle aspiration. If a nodule is detected either through palpation or seen on ultrasound or on another scan, we can go in with a needle right through the skin at the front of the neck and pull a sample using a small needle for things like cytology, and we use that to differentiate whether that nodule or tumor growth is benign or malignant. Thyroid cancer does occur. It's one of the cancers that is relatively easy to treat and deal with, but that's how we would differentiate benign versus malignant, is via that thyroid biopsy. Okay, so two major categories of alterations of thyroid function. The first is hypothyroidism, where we see an overall decrease in metabolic rate. We'll also talk about this accumulation of hydrophilic mucopolysaccharide substances. We call this myxedema. These start to deposit themselves in the connective tissue. And we also see elevated serum cholesterol in these patients. We'll talk about all those pieces. And the other issue that we see with thyroid is hyperthyroidism, where we get increased metabolic rate, increased oxygen consumption, increased use of metabolic fuels, increased sympathetic and nervous system responsiveness. Okay. So we're going to start with the manifestations of hyperthyroidism. Um, they're all kind of listed here for you to kind of look over. This picture came directly from your book, but our job and something we'll work on in class is we'll need to connect all of these manifestations of hyperthyroidism back to the overall effects of the thyroid itself. That's what I really want you to kind of be thinking about. We'll talk a little bit more about thyroid storm, but other things we see in hyperthyroidism: restlessness, irritability, and anxiety, wakefulness. These folks tend to not sleep as much. They have increased cardiac output. They have shortness of breath or dyspnea, tachycardia, and palpitations. They're not tolerant of the heat. They sweat a lot. They lose weight. They're thin. Their hair can become thin and silky. Their skin becomes thinned. They may have diarrhea. Their appetite goes up. And so you can look to kind of at the picture here to see sort of where all of those pieces sort of land. We see some muscle wasting. They might have tremors. Here we see what we call that myxedema, or that accumulation of that those tissues sort of below the skin. A lot of folks with hyperthyroidism, a lot of women with hyperthyroidism experience changes to their menstrual cycle. Hyperthyroidism may cause goiter. So those are just the general manifestations of hyperthyroidism. The most common cause of this is something called Graves' disease. We're going to talk about Graves' disease, but other things: multinodular goiter, adenomas of the thyroid gland, and general thyroiditis. Again, these signs and symptoms resemble central nervous system activity. Okay. So Graves' disease is the most common cause of hyperthyroidism. So Graves' disease is a state of hyperthyroidism. We also see goiter, so that enlargement of the thyroid gland in the neck, and what we call ophthalmopathy. And so you can see in this patient, they have sort of an enlargement and a bulging of their eyes. This can be a significant complication of Graves' disease. It can cause severe eye problems. It can cause changes to the extraocular muscles around the eye, which manifests itself in diplopia or double vision. It can start to damage the optic nerve, so people can start to lose vision. It can cause ulcerations on the cornea because sometimes the eyes enlarge so much that the eyelids can't completely close because of the protuberance. And so we get ulcerations on the eyes themselves. This condition of ophthalmopathy can start to stabilize if we, treat the underlying cause of the hyperthyroidism itself. We like to encourage patients to not smoke if they have that condition, because the cigarette smoke itself will start to cause even more dryness and damage to the eyes, some more corneal abrasion, that kind of thing. Okay. Graves' disease is an autoimmune disorder. And what's happening, it's characterized by abnormal stimulation of the thyroid gland by thyroid stimulating antibodies. And they act on and just like TSH. So these thyroid stimulating antibodies are binding themselves to the TSH receptors, and that's what's causing increased stimulation of the thyroid hormone, or the thyroid gland itself. And so it's growing in response to that increased stimulation. That's why we have goiter. And then it's also producing more T3 and T4. And so that's why we see elevated levels of those hormones in the blood and all those clinical manifestations of hyperthyroidism. Okay. There's familial tendency evident in Graves' disease, so we do see this more prominently in families. Okay. So let's talk a little bit more about thyroid storm. I mentioned it briefly in the manifestations of hyperthyroidism, but thyroid storm is an extreme and life-threatening form of thyroid toxicosis, or elevated thyroid hormone levels. We don't see this too often because we have good treatment modalities for hyperthyroidism in general, but it can happen in people who maybe don't have a diagnosis yet, or people who maybe are being undertreated for this diagnosis. And oftentimes it's precipitated by some stressful situation, like an infection or a physical and emotional trauma. So there's usually something that stimulates it or brings it on. Okay. The clinical manifestations that we see in thyroid storm are very high fever. Remember, we have this really high metabolic rate. So we have a really high furnace, really high burn, so we get a high fever. We see extreme cardiovascular effects, so extreme tachycardia. This can cause congestive heart failure and angina, which is chest pain. We see CNS effects like agitation, restlessness, and delirium. This carries a high mortality rate, so we need aggressive and early treatment to stabilize a person in thyroid storm. So treatment for this is what we call hemodynamic stabilization. So we have to deal with the heart rate. If we have congestive heart failure occurring, we need to deal with that. Um, We need to remove those thyroid hormones. There's a couple different ways we can do this. One is a technique called plasmapheresis. We can do this via dialysis. We need to cool this patient down, so we might use cooling blankets and other measures to try to bring down their temperature. We often give beta blockers that block that CNS activity or that activity of the sympathetic nervous system to bring down like the heart rate and those kind of things. We also have medications that block thyroid hormones themselves, so we might give those. We're going to replace fluid. We may give glucose or other electrolytes because we lose a lot of sugar and electrolytes when we have these really high metabolic rates. So that's essentially manifestation and treatment of thyroid storm. Okay, we're going to move on from hyperthyroidism to hypothyroidism, and we're going to start our discussion with acquired hypothyroidism. So these are patients who develop hypothyroidism later in life. We'll talk a little bit about congenital, so that's the reason for the distinction here. Primary hypothyroidism is the most common type, meaning it is originating right at the level of the thyroid gland itself. This can happen from thyroidectomy. It can result if someone takes in a large amount of iodine or if they have an iodine deficiency. These deficiencies are not something we see too much in the US, but they can happen in other countries that have maybe poor access to nutrition, those kind of things. In the United States, we put iodine in salt, and that's largely eliminated any iodine deficiency hypothyroidism here. We can also see postpartum thyroiditis. Some women develop thyroiditis after delivery that can cause hypothyroidism. This can also cause hyperthyroidism as well, so we can see both conditions postpartum. But the most common cause of acquired hypothyroidism is Hashimoto thyroiditis. It is an autoimmune disorder where we see the thyroid gland be totally destroyed by some immunologic process. It is the major cause of acquired hypothyroidism in children and adults, and it is predominantly seen, it's predominantly a disease of women. So women are the primary sufferers of Hashimoto thyroiditis. In congenital hypothyroidism, thyroid hormone is lost. So thyroid hormone is essential for normal growth and normal brain development, and most of that growth and brain development happens during the first 6 months of life. So it is essential to diagnose and treat congenital hypothyroidism to prevent damage or delay of this normal growth and brain development. So we really tend to do a lot of screening for congenital hypothyroidism in newborns to detect this condition so that we can treat it early and prevent those complications. Because if untreated, it can cause mental retardation and impairment of physical growth. And treatment is relatively easy. We just give thyroid hormone replacement therapy to prevent any of those side effects. Okay. So we'll talk about the manifestations of hypothyroidism. So here they are. Mental and physical sluggishness, mixed edema, somnolence or sleepiness. We get decreased cardiac output, bradycardia or slowed heart rate, constipation, loss of appetite, hypoventilation or reduced respiratory rate. These patients are intolerant of cold. Their skin becomes coarse and dry, as does their hair, and they tend to gain weight. Other things that we might see are peripheral edema. We might see changes to the menstrual cycle. One common thing that we see are loss of eyebrows, especially at the lateral aspect of the eyebrow themselves. It's sometimes interesting hair loss phenomenon to think about. People become pale, their tongue may enlarge. We sometimes see edema around the eyes and puffiness to the face. Sometimes the voice changes. It can become more deep or coarse. We might see gastric atrophy because we see all this kind of slowed peristaltic activity and maybe decreased food intake. Despite decreased appetite and food intake, we still see this increase in weight because we've got such a slowdown of our metabolic rate in general. Okay. One thing I'm going to mention is this mixed edema coma. A mixed edema coma is a life-threatening condition that we sometimes see with hypothyroidism. It causes extreme hypothermia and hypotension, and the mortality rate of that can be as high as 50%. I think we'll talk about that a little bit more in a bit, but that's a serious complication of hypothyroidism, similar to how thyroid storm was for hyperthyroidism. So the diagnosis and treatment, so we look at history and physical, and we'll look at lab tests. So we're looking for any of those clinical manifestations that might be associated with thyroid disease, either hyper or hypo. In the case of hypothyroidism, the typical lab values that we would see are low T4 and elevated TSH. So we're not producing enough thyroid hormone, and in turn, our pituitary gland isn't receiving negative feedback, and so it continues to produce more TSH. We also might look for antithyroid antibodies, looking for Hashimoto's thyroiditis. And for treatment of hypothyroidism, we would give synthetic T3 and T4 replacement, and we would periodically monitor our TSH levels, and we use that to monitor the efficacy of that T3, T4 replacement. This is a little bit more about myxodematous coma. Again, it's a life-threatening condition, and it's really an expression of late-stage hypothyroidism. We've reached a state where hypothyroidism has become so severe, our lack of thyroid hormone is so significant that our cellular metabolism has become severely reduced. And so patients present with extreme hypothermia. That extreme hypothermia is a strong predictor of mortality. They can develop things like cardiovascular collapse, hypoventilation and hyponatremia, severe hypoglycemia, lactic acidosis. The best way to treat this is really prevention. Talking to individuals who are at risk for hypothyroidism so that they understand the importance of proper treatment to prevent this condition from happening. Okay. Next, we're going to move on to adrenal function. So we're going to start our discussion with the adrenal glands themselves and just some of the overall information regarding adrenal control. So the adrenal gland contains two specific areas, the medulla and the cortex. The portion of the adrenal gland called the medulla secretes epinephrine, which is one of the neurotransmitters of the sympathetic nervous system, as well as norepinephrine, another SNS neurotransmitter. Okay. The cortex secretes glucocorticoids, mineralocorticoids, and adrenal androgens, and we'll talk about all of those. So if we lose total function of the adrenal cortical, if we lose total adrenal cortical function, total function of the adrenal cortex, that can be a fatal condition, and it can be fatal within days of this occurring if we don't treat it. Okay. ACTH is the hormone secreted by the anterior pituitary gland that controls secretion of our glucocorticoids and our adrenal androgens. So those things being produced by the adrenal cortex itself. We also had mineral corticoids here, but the stimulation for their secretion is a little different, so we'll talk about that specifically. But ACTH is really controlling glucocorticoids and adrenal androgen release. So these are the three hormones produced by the adrenal cortex. Our mineral corticoids, also called aldosterone, and the mineral corticoids function in sodium, potassium, and water balance. So mineral corticoids play an essential role in regulating potassium and sodium levels and in turn water balance. Sodium levels are the main driver of our water balance within the body. They're produced in the outer layer of cells in the adrenal cortex. Okay. Aldosterone secretion is regulated by something called the renin-angiotensin system and by blood levels of potassium. Okay. So increased levels of aldosterone, or these mineral corticoids, promote the retention of sodium within the kidney. So we hold on to more sodium. So as we release aldosterone, we increase our absorption and in turn our serum levels of sodium within the body. So sodium levels go up when we release more aldosterone. Okay. But what we also see with potassium is increased loss of potassium via the kidneys. So while we hold in more sodium, aldosterone signals the kidneys to excrete or send more potassium out within the urine. Okay. So the consequences of increased aldosterone are low potassium, and sometimes that manifests itself in things like muscle weakness. Okay. And the other consequence is increased sodium and increased water retention. So those are good things for you to kind of commit to memory, are the overall functions of aldosterone and how that relates to our serum levels of sodium and potassium and how it relates to overall water balance. Okay. The other things produced here, glucocorticoids or cortisol, those really aid in the regulating of metabolic functions and inflammatory processes. These are essential for survival, especially in stressful situations. We're going to talk a little bit more about those in a moment. We also see some production of androgens or sex hormones in the adrenal cortex. They're mainly a source of androgen for women. They have a much smaller role in overall functioning than the glucocorticoids and mineral corticoids. They're more of an adjunct production to our normal production of sex hormones by the ovaries and testes. So just the amounts of androgens that the adrenal glands secrete is relatively low. We're not going to really talk about this too much because primarily the function of the sex hormones is really driven by the ovaries and testes. This is a very small portion of that. But let's talk a little bit more about the glucocorticoids. So the glucocorticoids, these are the stress hormones that are released from the adrenal glands. Okay. Let's see where to start. So one thing I'll mention with glucocorticoids is that we see a lot of what we call diurnal variations in their release. So what that means is we see various levels of glucocorticoid release based on time of day. The release of glucocorticoids or these stress hormones peaks really early in the morning. I think usually between like 4 and 6 a.m., right before someone is getting ready to wake up. We're going to talk about that and its relevance to things like blood sugar control, but do know that we see a peak of action really early in the morning. And then the overall secretion of cortisol tends to sort of decrease kind of throughout the day, with the early evening time being the lowest level of cortisol secretion. So we see varying levels of secretion of cortisol based on time of day, and we call that those diurnal variations. Okay. So glucocorticoid blood levels of these hormones are regulated by negative feedback mechanisms of that HPA system, so the hypothalamic pituitary axis. Okay. So just as other pituitary hormones are controlled by releasing factors from the hypothalamus, corticotropin releasing hormone, or CRH, we see that right here, is the hormone that controls the release of ACTH at the level of the pituitary, okay? And different stressors exert their effect on the hypothalamus to signal it to release more CRH. And those stressors can be a variety of things. They can be general stress itself, they can be infections, they can be pain, hypoglycemia or low blood sugar, lack of sleep, hemorrhaging or blood loss, or trauma, surgeries. Lots of different stressors on the body signal the hypothalamus to produce more CRH, okay? And that CRH release stimulates the anterior pituitary to release more ACTH, and the ACTH stimulates the adrenal cortex to release more cortisol. Cortisol goes out and exerts itself on those target tissues. This also has a negative feedback mechanism as we increase the amount of cortisol. That feedback primarily works to tell the pituitary to stop producing ACTH, but there's also a lesser effect of feedback inhibition on the production of CRH. The primary feedback mechanism works here, but there is also some here. So that's in general how we control the action of glucocorticoids within the body. Okay. So when we release cortisol and it exerts its effect on tissues that have receptors for it, these are the general actions that we see. One is an increase in glucose metabolism. So we see a general overall increase in glucose production when we increase levels of cortisol. So we might absorb more glucose in the intestine, and we're also going to see more breakdown of products within the liver to release glucose into the system. Okay. We see more breakdown also of proteins and fats to release more energy with the excretion of cortisol. Cortisol suppresses the inflammatory response and the immune system. Cortisol also has some psychological effects. This hormone appears to be directly related to different emotional behaviors. So with cortisol secretion, we see this kind of labile emotional state sometimes with these patients. There are receptors for cortisol within brain tissue, so we think it does play a role in the regulation of behaviors. Okay. The final thing here is what we call permissive effects. And permissive effects refers to the increasing action of different things like glucagon and adrenaline that are released during times of stress. So the release of glucagon helps us to increase the amount of circulating glucose, which is necessary during stressful situations. And we also release more adrenaline. And so cortisol can increase the action of both glucagon and those adrenaline secretions within the body. Okay. All right, so there are different levels that we can see in adrenal cortical insufficiency. We can have primary adrenal cortical insufficiency that's happening right at the level of the adrenal gland itself. We term this Addison's disease, okay? In these patients, if we look at blood levels of ACTH, which again is being released by the pituitary, these levels will most likely be elevated because the disease is at the level of the adrenal glands themselves. So we're not producing things like cortisol, which would turn off the production of ACTH. There's no feedback inhibition. So in Addison's disease, we see the absence of cortisol or the absence of glucocorticoids, but we see increased levels of ACTH. Secondary adrenal cortical insufficiency occurs in cases of hypopituitarism, so maybe a surgical removal of pituitary gland. So in these patients, we have both absence of ACTH and absence of cortisol production. Complete lack of glucocorticoids is a life-threatening situation. So Addison's disease, again, is primary adrenal insufficiency. So deficient adrenal cortical hormones with elevated ACTH levels. It's pretty rare, but it's usually caused by some sort of autoimmune destruction of the adrenal glands itself. And in Addison's disease, we have both mineralocorticoid deficiency and glucocorticoid deficiency. So you'll need to understand the actions of both glucocorticoids and mineralocorticoids to fully understand the clinical manifestations that we see in a patient with Addison's disease. Okay. So these are the clinical manifestations that we note. So one, anorexia and weight loss. We see dehydration, fatigue, and weakness, GI upset, nausea, diarrhea. We see muscle pain, joint pain, abdominal pain. We also see this hyperpigmentation where the skin kind of has this bronzy tone to it. This happens because of the buildup of ACTH within the system. So remembering that the pituitary gland continues to produce ACTH in patients with Addison disease, and that ACTH starts to cause this pigmentation of the skin. We see orthostatic hypotension, hyponatremia, hypoglycemia, and hyperkalemia. So remembering that mineralocorticoid deficiency causes increased urinary losses of sodium and water. So these patients with adrenal insufficiency are losing sodium through the urine. It's taking a lot of water with it, so they get dehydrated. They can get orthostatic hypotension because they don't have good circulating blood volume. But they also are not excreting as much potassium because of that loss of aldosterone. So what we see in our patients, if we test serum levels of sodium and potassium, we see hyponatremia and hyperkalemia in these patients. Okay, these patients have significant stress intolerance. So without stress hormone production, we see poor stress tolerance. Hypoglycemia happens because we don't have any of that action of cortisol to increase glucagon production and to increase circulating hormones. Okay. So again, all of these are clinical signs and symptoms of Addison's disease. Okay. So how do we treat adrenal cortical insufficiency? Well, we have to give stress hormones, right? For mild cases of adrenal cortical insufficiency, we can give maybe just hydrocortisone itself. If we have patients who are still not retaining enough salt, we do give something called fludrocortisone, which is a straight mineralocorticoid to help them retain more sodium. Okay. Another important piece here is making sure that our patients understand to eat regularly and to exercise on a very specific schedule surrounding those meals. Because again, these patients are very prone to hyponatremia and hypoglycemia. They lack a mechanism to increase their blood glucose in the absence of food. So at times of starvation or at times of increased stress where we need more circulating glucose, they do not have a mechanism to do that. And so the only mechanism is to make sure that they're taking in enough glucose to prevent severe hypoglycemia. These patients don't respond well to things like infection or trauma or stress. So if these situations occur, patients with cortical insufficiency need immediate medical attention. And so we often advise them to wear a medical alert bracelet in those to alert healthcare providers in those times of stress that they need that medical attention. So again, an acute adrenal crisis can be life-threatening and is often precipitated by some minor stress or illness in those with Addison disease. The clinical manifestations we see here: nausea, vomiting, extreme muscle weakness, hypotension, severe dehydration, and if we lose enough fluid, right, we can get vascular collapse. Treatment of adrenal crisis, we talk about this in terms of the 5 S's of management. So it's salt replacement, sugar replacement, steroid replacement. So we've got to give back those adrenal steroids that we're not producing. We have to support all those physiological functionings, whether it's giving fluid, whether it's preventing further vascular collapse, bringing blood pressure back up. whether it's treating things like severe hyperkalemia. And then the last S is search for the cause. We have to figure out why they went into adrenal crisis to try to reverse that. Okay. We're going to move on now to glucocorticoid hormone excess. We call this Cushing syndrome or hypercortisolism. Okay. There is a pituitary form, and this results from excessive production of ACTH at the level of the pituitary. It's often caused by a tumor of the pituitary gland itself. And we also have an adrenal form. So the most common cause of this is some sort of benign or malignant tumor within the adrenal glands itself that's causing this hyperproduction of glucocorticoids. There are also some what we call ectopic forms of glucocorticoid hormone excess. So we have a non-pituitary ACTH secreting tumor somewhere. So there's some malignant tumor outside of the pituitary gland itself that has started to independently produce ACTH. So kind of three causes of glucocorticoid hormone excess. So clinical manifestations are the result of this exaggerated action of cortisol. So if you understand the actions of cortisol itself, you can also understand the clinical manifestations that we see with this. So we see an overall altered fat metabolism in excess glucocorticoid production. And how this manifests in our patients are these kind of bizarre fat deposit or fat storage changes within the body. And so I'll show you some of these. So one is this increased depositing of fat in the face, and we sometimes call this a moon face. So we see these changes to their face. We also see increased deposits of fat on the upper back. We call that a buffalo hump. And we also see increase in fat deposits within the abdomen itself. So we see this kind of more pendulous looking abdomen. So those are the fat distribution changes we see with that altered fat metabolism. Without the function with exaggerated cortisol function, we also start to break down more muscle tissue. So we get muscle weakness, and we also get these thin extremities. And so you can see kind of how we have muscle wasting within the legs or within the arms. So people with Cushing syndrome get this very specific body shape where they have an increase in their abdominal size, along with thinning and smaller extremities, legs and arms, from that muscle weakness and protein breakdown. Skin starts to become quite thin, and so that often manifests itself in things like abdominal striae. So if we've got expansion of the abdominal adipose tissue itself, in addition to thin skin, we start to see these what we call stretch marks of the skin itself in response. We also see this in the extremities where we see maybe thin and wrinkled skin. Okay. Another typical manifestation is osteoporosis. We get a lot of bone breakdown and calcium release with increased action of cortisol. With that increased release of calcium from the bones, we have a higher incidence of kidney stone formation. Hypokalemia also occurs. We have an increased production of mineralocorticoids here as well that cause an increase in loss of potassium. So hypokalemia is common in Cushing syndrome, but we're also getting an increased absorption of sodium and water with it. So we see hypernatremia and hypertension as our circulating blood volume increases. Cortisol inhibits the inflammatory and immune responses in patients. So we see a reduction in inflammation and a reduction in immune response. Cortisol also stimulates the GI tract, and it stimulates GI secretions. So these patients are at higher risk of things like GI ulcers and GI bleeding. Cortisol has direct effects on emotions and behaviors. So we see some emotional lability or instability. And in women, we sometimes see the production of hair on the face. That's hirsutism. We might see some mild acne, and we might see changes to menstrual cycles. These symptoms are related to the increased release of androgens from the adrenal cortex. Okay. So, diagnosis and treatment. Untreated Cushing's syndrome can produce serious morbidity and even death. And so we do want to diagnose and treat this condition. There are kind of two steps to this. The first step is to diagnose that hypercortisolism is there. And then the second diagnostic step is to try to determine the cause of that hypersecretion. So remember back, we had those kind of three distinct causes of increased cortisol production. So we have to figure out where it's coming from. So this first group of tests are the things that we use to diagnose the presence of hypercortisolism. So 24-hour urinary free cortisol levels. So we collect urine for 24 hours and look at the cortisol levels within that urine. Midnight plasma and late night salivary cortisol measurements. So remembering that the timing of these is really important, and that has to do with those diurnal variations in cortisol levels themselves. And so we want to be very specific about the time when we collect many of these tests, because if we collect at the wrong time, we could see really low or really high levels of cortisols, but they're just diurnal variations. So the timing of these is really important. Okay. So again, these are the common tests that we use to detect the presence of hypercortisolism. Okay. Okay. CRH stimulation tests, high-dose dexamethasone suppression tests, and radiological imaging are the tests that we use to determine the causes of hypersecretion. So CRH stimulation tests can help us determine, whether or not we have, at what level we have an issue with cortisol production. Okay. So the overall goal of treatment here is to remove or correct the source of hypersecretion. So that's why it's really important to determine the cause, because that's where our target of treatment is going to be. And we want to do those things without permanently damaging either the pituitary gland or the adrenal gland. One thing I'll point out here is one of the common treatments, if it is pituitary, if it's a pituitary tumor or a pituitary problem causing this, a common treatment is what we call transsphenoidal removal of that pituitary adenoma or of the pituitary gland itself, meaning that we go in through the nose to remove that pituitary gland. Okay. At this point, we're going to end our discussion of overall endocrine disorders and move into the portion on diabetes. So you can stop the recording here and pick it up later when you are interested in learning more about altered glucose regulation. So now we're going to move into our discussion on altered glucose regulation. So we're going to start with the different ways that our various glucose regulating hormones control glucose, fat, and protein metabolism. So we're going to start with the metabolism of glucose. So one thing to understand about glucose is that it's the exclusive form of fuel for the brain. We have to have circulating levels of glucose to provide the energy needs of the brain itself. And the other thing to understand about glucose levels is that as glucose levels in the blood rise, that signals the release of insulin from the pancreas. And then that increase in insulin in turn facilitates the entry of glucose into the cell. Glucose has to go into the cell for us to be able to break it down to use it for energy. Glucose circulating the serum does no good for us as far as energy production. Okay. And glucose is either used for the metabolic our immediate metabolic needs, or if the amount of glucose we take in exceeds our immediate metabolic needs, we store the rest of that glucose in the liver as glycogen. Okay, so you can see from my diagram here, we have increased blood glucose. And so some of that blood glucose goes into the skeletal muscle where it's stored potentially as glycogen for use later. Any blood glucose in excess of what we immediately need can be stored, and it's typically stored in potentially in adipose tissue as well. And then we also can send excess glucose to the liver, um, where it can be stored as glycogen, and then we can break down glycogen later if we need more glucose. Okay. In fat metabolism, um, if we're breaking down fats, the metabolism of that fat or triglycerides produces a glycerol molecule and 3 fatty acids. And those fatty acids in turn can be used as fuel by most of the cells in our body. Not the brain, because remember we just use glucose for that, but all of our other cells can use fatty acids for fuel. This is an important mechanism that we use to continue to power and provide energy to the body, even in the absence of glucose. So in times of like starvation or fasting, where we don't have any readily available glucose for fuel, we can go ahead and break down fats to produce these fatty acids that we can then use for fuel. Okay. So in a fasting state, we start to use our glycogen stores and we start to break down fatty acids from our fat cells. Okay. The end result of this breakdown of fatty acids is something called ketone bodies. So if our body is breaking down fatty acids as a fuel supply, we're also releasing these ketones. Okay. So when we have ketone production by the liver during fasting conditions, so we have a fasting state, um, the pancreas itself is now not producing any insulin because there's no glucose to stimulate it to do so, but it's starting to kick out some glucagon because it needs additional sugar. We'll talk about that momentarily. And we're also in that fasting state starting to break down those fat cells. Those fat cells are broken down into our fatty acids, and those fatty acids can be used for fuel. Within the liver, those fatty acids are producing ketones, okay? And that increased ketone production also increases ketones that are circulating within the bloodstream, okay? So it'll be important to kind of understand that piece of fat metabolism that occurs during fasting states where we lack blood glucose, for you to be able to understand some of the additional, I guess, complications that we see in diabetic patients later on. Okay. The final thing we'll talk about is protein metabolism. So remembering that proteins, here are my little proteins right here, are made up of amino acids, okay? We do not have a great or a large storage mechanism for amino acids in the body. We need to take these guys in primarily with food, okay? If we take in more amino acids in excess of those that we need for immediate protein synthesis within the body, we then convert those amino acids to things like fatty acids. We can also convert them to ketones, or we can convert them to glucose. Okay. So we take in food, the protein we take in the food, here it is right here, broken down into amino acids. We use those amino acids to produce protein, seen right here. And we also can use those amino acids to produce glucose that can go into energy production. Okay. You note here that in times of starvation, where we don't have enough energy production for muscle tissues, we also can start to break down muscles themselves. Okay. Now we start to get amino acids being pulled from protein synthesis that can then get fed into this glucose production pathway. Okay. You'll notice this little graphic kind of talks about all of those mechanisms of glucose and fatty acid metabolism from food intake. So I'm just going to kind of use this little diagram to go back through the other two that we've already talked about to make sure that they're kind of solidifying themselves for you, okay? So in food intake, again, we're going to look at the metabolism of fats. So as we take in fats, those are broken into triglycerides, okay? And those triglycerides are broken down into our fatty acids, okay? Fatty acids can be used as fuel by all tissues except the brain. And excess fatty acids are then stored typically in our lipids or in those fat cells. In times of starvation, we can break down those lipid stores to then again produce glycerol and fatty acids that can go into energy production. Okay. If we look at breakdown of carbohydrates, we can directly use glucose in the cells for energy production, but understanding that insulin is necessary here to get that glucose into the cells. And our excess glucose goes into the liver to be stored as glycogen to be used later and also in the skeletal muscles. Okay. So really kind of focus on and understand the complexities of some of that metabolism of all those various portions of our diet, because they're going to be important for you to be able to understand what happens when we have alterations in things, especially right here. Okay. All right. So now we're going to talk about the specific hormones that regulate glucose. And we're going to start with insulin. Okay. So insulin is the only hormone in our body that acts to reduce blood sugar. We're going to talk about a lot of different hormones involved in the regulation of glucose. Insulin is the only one that can reduce blood sugar. The rest of them are really going to act to increase it. Okay. Insulin is produced by the beta cells within the pancreas. Insulin also functions to promote the storage of fat. And insulin also increases protein synthesis and helps to inhibit the breakdown of proteins in general. Okay. So insulin acts by promoting glucose uptake by target cells. It also increases the storage of glucose within the liver as glycogen and the storage of glucose in fat as adipose tissue. It inhibits the further breakdown of fat and it inhibits the breakdown of glycogen. It inhibits gluconeogenesis, we'll talk about all these, and increases protein synthesis. Okay. So let's look a little bit more in the diagram to talk about a few of those things more specifically. So this is normal insulin function, and its normal function is fuel storage. Okay. So we'll start right here where we have an increase of blood glucose within the body, right? Maybe I had a big meal, and so I've absorbed all of this glucose from what I ate, and my serum levels of glucose are going up. Increased glucose levels stimulate the pancreas. Here's my pancreas, where my beta cells can produce insulin in response to elevated glucose levels. That insulin is secreted by the pancreas into the serum, and it has all of these different effects on fuel. One effect of insulin is on the liver. In the presence of insulin, glucose is stored within the liver itself as glycogen. And that glycogen sits there in the liver, and it's sitting there to be used later on if we need to increase the levels of glucose in the blood and we don't have enough glucose readily available in the serum. So glucose is stored in the presence of insulin as glycogen in the liver. Gluconeogenesis is the process that happens in the liver when we break down glycogen stores to increase serum glucose levels. So in the presence of insulin, Because insulin is stimulated by high glucose levels, its presence tells the liver, hey, we probably have enough glucose right now because we have enough glucose to excrete insulin. We don't need you to produce anymore. So insulin turns off gluconeogenesis. Okay, so those are the insulin effects on the storage of glucose and the inhibition of further production. Okay, insulin also stimulates the storage of glucose into fatty acids. Okay, so insulin promotes fat storage. So the presence of insulin, if we have excess glucose, insulin will help to store that glucose in the fat. Remember back to the metabolism of fat, right? We can break down these adipose stores to produce fatty acids that we can use as fuel in times of starvation. So this function of insulin to increase fat storage, evolutionary-wise, allows us to continue to function and our cellular metabolism to continue, even if we don't have readily available supplies of glucose. And your body has infinite ability to increase its storage of fat. Okay. The other action of insulin is to promote the intake of glucose into the muscle tissues. Okay. And when that glucose uptake is happening, we also reduce the amount of protein breakdown that happens because we don't need any amino acid release into the liver. Okay, we have plenty of glucose being produced, and the insulin is pushing that glucose into the muscle. The muscle's able to function. It doesn't need to break itself down to release any amino acids to help further fuel the body. Okay, so when insulin is present, we don't get any protein breakdown. We just get protein synthesis because we have adequate amounts of glucose. We don't need those amino acids to be broken down to provide energy. Okay, so thinking about this piece in relationship to the last diagram that we showed that talked about all of those different ways that we get energy from the food we take in, whether it's carbohydrates, fat, or proteins. Okay. Another glucose regulating hormone is glucagon. Okay. Glucagon is released by the alpha cells within the pancreas, and its release is stimulated by low blood sugars. Okay. When we release glucagon, we stimulate the breakdown of glycogen in the liver. And so remember, glycogen is how we stored glucose within the liver. If we start to break down glycogen in the presence of glucagon, we increase production of glucose that can be sent out into the serum to provide us energy during times of fasting. Okay. Glucagon also increases gluconeogenesis from protein conversion to glucose. So glucagon can break down proteins so that it can produce more glucose. Okay. So here we see the action of glucagon, and it has actions on the muscles, it has actions on the liver, and it has actions on the adipose tissue. All the places where we store glucose essentially to be released during times of starvation to increase the blood glucose levels. So again, glucagon is a peptide hormone. We produce it in the alpha cells of the pancreas. It increases the concentration of glucose and the concentration of fatty acids in the bloodstream. It is the main, what we term catabolic hormone of the body. During catabolism, we are breaking things down, okay? So with glucagon, we go in and we break down adipose tissue to release fatty acids to go into the liver to provide energy. Ketones are produced in the process. Okay. So glucagon acts on adipose tissue to stimulate the breakdown of fat cells, the release of fatty acids. The fatty acids are metabolized in the liver. They produce keto acids. And the overall effect of glucagon is that glucose, fatty acids, and ketone acids are elevated in the blood. Okay. Glucagon also acts on the liver to break down glycogen to produce glucose. Okay. And glucagon also acts on the muscles to produce glucose and break down that muscle tissue to release amino acids. Okay, so amino acids are released from the muscle in response to glucagon, and they're converted to glucose in the liver by gluconeogenesis. Okay, so we're sending amino acids from the muscle, we're sending fatty acids from the adipose tissue, and we're directly acting on the glycogen in the liver to create more glucose. The end result, more glucose released into the serum. And again, this happens during times of starvation, during times of absence of glucose within the body. We get all of these actions stimulated by glucagon. Okay. All right. A couple other glucose regulating hormones that we'll talk about, somatostatin, amylin, some other hormones that are primarily derived from the gut itself. I'm not going to go into these too much. I'm just going to tell you the overall action of things like somatostatin appears to be increasing the amount of time that the nutrients from our food are available in the bloodstream. So it kind of slows the overall uptake of these nutrients from the bloodstream itself, so they circulate longer. Amylin works in conjunction with glucose to slow gastric emptying and to suppress the actions of glucagon. Okay. This particular image that I have here doesn't necessarily relate to somatostatin, but I just threw it in here because I thought it was another helpful image to have you think about what's happening during times of either presence or absence of glucose. So if we have high blood sugar, we promote insulin release in the pancreas, and that insulin stimulates glucose uptake into the cells. It stimulates glycogen formation, okay? But then in times of low blood sugar, we promote glucagon release. Glucagon release stimulates glycogen breakdown, so we can release glucose. So this might be another helpful graphic to help you understand what's happening during times of excess sugar or not enough sugar, or during times of starvation, okay? All right. The final thing we're going to talk about as far as glucose control are glucose regulating hormones. These are our counter-regulatory hormones, or our anti-insulin hormones. And so they are epinephrine, growth hormone, and glucocorticoids, right? And so here they are right here. And so remember, we said that insulin is the only hormone that can lower blood sugar. And so these other counter-regulatory hormones all work to raise blood sugar. So if we release growth hormone, if we release cortisol, if we release epinephrine, these things will work to increase serum levels of glucose, okay? So now we're going to talk about some of the different tests that we can use and the diagnostic criteria that can be used to classify people as either, normal blood glucose, impaired, pre-diabetic, or diabetic, some of those things that we use. So, where's the cutoff as far as some of these testing numbers to determine that someone is indeed diabetic? So the first blood test that we'll talk about is the fasting plasma glucose test. In a fasting plasma glucose test, someone is fasting, meaning they haven't taken in any food or drinks for, I think it's 8+ hours. So we can ensure that there should be no circulating glucose in those patients beyond just the normal levels. So a normal FPG level is below 100. So below 100 is considered normal. If someone is between 100 and 125 milligrams per deciliter for an FPG, we would consider that significant, and we define it as impaired fasting glucose. If someone has a level of FPG level greater than 126, we consider that diagnostic for diabetes, okay? A random glucose test is blood glucose testing that is done without regard to food. So at any point during the day. So we're unsure of how much food intake. So we don't use kind of the same thresholds or numbers that we do for fasting blood glucose. But a random plasma glucose concentration that is elevated, typically greater than 200, and a person with classic signs of diabetes like polydipsia, polyphagia, polyuria, blurred vision, or if we get a random blood glucose greater than 200 in a hyperglycemic patient in crisis, those are now diagnostic of DM, okay? So a random blood glucose level greater than 200 on a completely asymptomatic patient or someone not in some sort of diabetic crisis, we would not diagnose them with diabetes. But if they have the classic signs and symptoms of that, it could be diagnostic, okay? The next thing is the oral glucose tolerance test, the OGTT. This is something that we commonly use, especially in pregnant women when we're trying to screen for things like gestational diabetes. But we're measuring the plasma glucose response to the ingestion of about 75 grams of a glucose solution. So we have someone come into an office, we give them a really highly sugar concentrated drink, and then we have them sit there for a couple of hours and check their blood glucose at random times to see how quickly it's kind of coming back down to baseline. So usually at selected intervals, maybe at 1 hour, maybe at 2 hours. In people with normal glucose tolerance, blood glucose should return to normal levels within 2 to 3 hours of taking that glucose load. If they don't, especially if they remain greater than 200 milligrams per deciliter after 2 hours, we might consider that diagnostic of diabetes. Okay. Capillary whole blood glucose monitoring. This is what we commonly do. This is finger stick monitoring. And this is the type of monitoring that our patients do usually for day-to-day diagnostic measurement of their blood glucose. This is the type of monitoring that we use to do things like determine how much insulin someone should be taking. This is the daily management piece. Okay. And the final serum test we'll talk about is a hemoglobin A1C. A hemoglobin A1C, or a glycosylated hemoglobin, gives us a measure of glucose management over time. Typically, it gives us a snapshot of how well someone has been controlling their blood sugars over the last 3 months. Okay. These A1C levels correlate to a mean plasma glucose level. If we have someone with a hemoglobin A1C greater than 6.5, we would consider that diagnostic of diabetes. And so you can kind of see how that works out here, right? So here are my hemoglobin A1C measurements way over on this side. And so if someone has a blood glucose or an A1C level less than 5.7%, we consider that normal. That correlates with an average daily glucose level of about 100 and less than 117. And so remembering that less than 117 also is the same numbers as we see normal fasting plasma glucose levels, right? And so we consider that person normal. In a pre-diabetic patient, we might see an A1C between about 5.7 and 6.4. And so that's a patient whose estimated daily glucose levels are running between about 117 to 137, right in those kind of pre-diabetic impaired fasting glucose number ranges, right? So these correlate. As hemoglobin A1C percentage numbers rise, so do the estimated average blood glucose levels. So if we have someone who comes in with a hemoglobin A1C of 8, we're estimating that on a day-to-day basis, their plasma glucose levels are 183 or more. So the higher the A1C, the higher the daily estimates of fasting blood glucose. So these really speak to how well someone is controlling their blood glucose. So we use A1C not only as a diagnostic criteria, but we often use it to determine how well someone is managing their diabetes, especially in type 2 diabetic patients who are maybe managing with things like dietary changes, where we're not maybe checking blood glucose levels frequently. We can look at an A1C and give us a sense of how well they're controlling those things day to day. Okay. There are also some urinary tests that are diagnostic and useful within diabetes. One is urinary glucose levels. So if we are sensing or if we are picking up glucose in the urine, it means that we've surpassed what we call the renal threshold for reabsorption of glucose. It means that there's so much glucose entering the kidneys from the blood that we're just overwhelmed with the amount of glucose. We can't reabsorb any of it, and so it starts spilling out into the urine. Having glucose in the urine is not a normal state. Usually if we see glucose in the urine, we also see serum hyperglycemia. The other urinary test is urine ketones. So if we have someone who is spilling ketones out into the urine, it indicates that the body is producing excessive ketones. And that indicates that we are not using glucose as our energy source. That indicates that we're using probably the breakdown of adipose tissue into fatty acids for supply. And so when we see elevated ketones in patients, it means they're unable to use glucose as a source of fuel. So for patients who are diabetic, they might also be hyperglycemic because they're not producing any insulin. All of that glucose is circulating in the serum. It can't be used by the cells, so they have to use fatty acids to power the cells, and that produces ketones. Those ketones spill out into the urine. Okay. So a little bit more about the classifications of different types of diabetes and their pathophysiology. Um, we have this term pre-diabetes. In these patients, the glucose numbers don't meet the threshold for diagnostic yet, but we probably need them to start engaging in lifestyle modifications. So maybe this is someone who has impaired fasting blood glucose, and so maybe dietary changes or more exercise, something like that would be recommended here in these pre-diabetic patients. This is a classification that we really have for type 2 diabetes. In type 1 diabetes, we have autoimmune destruction of the beta cells within the pancreas. And so because these beta cells are being destroyed, we have the absence of insulin production. So in type 1 diabetes patients, these patients become what we call insulin dependent because they are not producing any insulin at all. The causes of this are usually multi-gene and environmental factors. There is a genetic component here. There are probably multiple genes that code for the production of antibodies against these beta cells, but most likely those genes also need to be sort of turned on by some environmental influence. This creates an overall catabolic state where we start to break down adipose tissue, where we start to break down muscle tissue in an attempt to increase energy production. Okay. In type 2 diabetes and metabolic syndrome in general, that we'll also talk about, we get hyperglycemia, so elevated levels of blood sugar, with a relative lack of insulin. So in type 1 diabetes, we have a complete absence of insulin. In type 2, it's relative. So these patients still produce insulin, but it is not having the same overall effect that we would consider normal as far as decreasing blood glucose levels, right? There's a strong genetic component as well to derangement of insulin secretion. So we tend to see type 2 diabetes also traveling within families, as well as an environmental component. The most significant environmental component is obesity. Obesity is strongly related to the increase in insulin resistance, meaning we're still producing insulin, but the body is just not reacting to it as strongly as it was previously. Insulin levels may be high, they may be normal, they may be low. So a lot of what we see in type 2 diabetes, the signs and symptoms might be independent of the amount of insulin available. And the lack of insulin sensitivity that we see in the liver also leads the liver to continue to produce glucose even when it's not needed. Remember, one of the functions of insulin on the liver was to reduce the production of glucose. It was to reduce gluconeogenesis. And so if we have cells in the liver that now can't respond to insulin itself, the liver is going to still continue to create that glucose, even though we have enough in the circulation. Okay. All right. So let's look at the picture a little bit more to kind of see some of the ways that type 2 diabetes develops. So we maybe have a bit of a genetic predisposition, but we also have some environmental factors, often obesity, and that genetic predisposition can start to cause derangements in how insulin is released from the pancreas itself. So maybe we're just producing or releasing less insulin. And those environmental factors, as well as genetic predisposition, can also increase what we term insulin resistance, meaning that all the areas within the body that have receptors to insulin don't react to them as strongly as they normally do, right? And so we have receptors for insulin actions in the liver, we have receptors in the muscles, we have receptors in many of the cells in our body. So we're potentially producing less insulin. We're also increasing the resistance to our insulin. And so at the level of the muscle, we see less uptake of glucose into those cells. And so now we've got more circulating blood sugar. So we have hyperglycemia. We also see increased resistance to those receptors within the liver. So the liver continues to output glucose despite that. So that further increases our blood glucose levels. And so those two things, now we've got a patient with hyperglycemia from type 2 diabetes. Okay. The other piece of this is something called metabolic syndrome. Type 2 diabetes is closely associated with insulin resistance syndrome, otherwise known as metabolic syndrome. This is probably the most common term for metabolic syndrome. The clinical manifestations of metabolic syndrome include central obesity. So that's like a waist circumference greater than 40 in men and greater than 35 inches in women, 40 inches, 35 inches. So central obesity. These patients also have elevated triglyceride levels in the body. So usually triglyceride levels above 150 milligrams per deciliter. They have low levels of HDL, or our good cholesterol, so less than 40 in men, less than 50 in women. They have high inflammatory markers. So there's a blood test we can do called CRP. C-reactive protein is what that stands for. We often see elevated levels of C-reactive protein in patients with metabolic syndrome. Again, that indicates high levels of inflammation within the body. And they usually have hypertension, so high blood pressure is also a hallmark of metabolic syndrome. They also have a high risk of developing vascular disease, so things like cardiovascular disease, cerebrovascular disease, peripheral vascular disease. All of these changes in things like cholesterol and inflammation start to damage the blood vessels. That in turn leads to all this elevated risk of vascular disease. So when we talk about metabolic syndrome, we need at least 3 of these 5 markers to diagnose someone with metabolic syndrome. And again, these go hand in hand very closely with type 1 diabetes. And so you can see high fasting blood glucose as part of that as well. Okay. All right. There are some other types of diabetes as well. One is gestational diabetes. So this is diabetes that develops, or glucose intolerance that develops during pregnancy. We do need to monitor for and test for diabetes in pregnant women because its presence will increase complications of pregnancy, like increased fetal size, and infant hypoglycemia. So infants born to mothers with gestational diabetes have these sudden and severe drops in their blood glucose directly after birth. One potential complication of gestational diabetes. The other piece of gestational diabetes If someone is diagnosed with GDM, it increases the likelihood that they'll later be diagnosed with type 2 diabetes. And so those patients with gestational diabetes need to be screened more closely and more frequently for type 2 diabetes after giving birth. There are some other causes of diabetes: pancreatic damage or removal, acromegaly, Cushing's, and pheochromocytoma. So now we're going to talk about some of the specific clinical manifestations of diabetes, and we're going to start with the clinical manifestations of type 1 diabetes. There are similarities, but some differences, and so I'll try to also make those sort of clear as we go through these two discussions. So signs of DM1, one difference between DM1 and 2 is that in DM1, the signs and symptoms appear really pretty suddenly. In these patients. So the classic hallmark signs that we see are polyuria, polydipsia, and polyphagia. So increased urination, you can see my little friend's headed to the bathroom, excessive thirst, constantly drinking, and excessive hunger. Here she is with her little kind of takeout bag. So polyuria, polydipsia, and polyphagia. And so if we think about the pathophysiological reasons behind this, remember that in type 1 diabetes, we have a complete lack of insulin. And so now we're not able to take glucose up into the cells. We're not able to do the different aspects of storage, either into the fatty tissue or into, it's not going to the muscles, it's not going into the fat, it's not going into the liver, it's just sitting out in the serum. And if we have all these elevated levels of blood sugar within the serum, we have an elevated number of solutes within the serum itself. And remembering back to our discussion of how different things like solutes and water move across a cell membrane, one of the things that drives osmosis, or the movement of water across a cell membrane, is that water is moving from an area of lower concentrations of solutes to an area of higher concentration of solutes. So if we have someone with a high level of sugar within the serum, it's going to start to pull water into the bloodstream. And so we're going to have all this circulating water, but we're going to lose that water from the cells itself. It's going to be pulled away from the cells and out into the bloodstream. And that dehydration, or that loss of fluid inside of the cells in response to those high levels of sugar, are what give us that sense of that excessive thirst. So our cells are sitting there saying, hey, we don't have enough water, we're all dried up, we need to drink more. And so these patients experience polydipsia. All of that excess water being pulled into the serum is now headed to the kidneys. And so these patients urinate a lot in an attempt to get rid of that fluid. And the final piece, polyphagia, is happening because now with all that circulating glucose out in the serum, we can't use it as an energy source. So these patients are essentially sensing that they're starving, right? And so their body keeps saying, we don't have enough energy here, let's eat more. And so that's the pathophysiologic reason behind polyuria, polydipsia, polyphagia, all of them driven by those increases in blood glucose levels within the body in the lack of insulin, okay? Despite eating more, despite having more circulating blood volume, these patients tend to lose weight because they're in a catabolic state, right? We're breaking things down. We're breaking down fatty acids for energy. We're breaking down muscles for energy. We don't have energy supply from glucose, so we're going to just start to break things down to provide those energy sources, and that manifests itself in weight loss in our patients. They may also get some really common things like blurred vision. They may have excessive fatigue. We might see skin infections in these patients. A couple other things I'll mention about diabetes that's type 1 that sets it apart from type 2. These are going to be insulin dependent patients. They have to take insulin to live. There's a familial tendency here. There also is in type 2 diabetes. The peak incidence of onset of type 1 diabetes is between the ages of 10 to 15 years old. That's when we see the majority of people diagnosed with DM1. It can happen in other points, either earlier or later, but this is the highest rate of highest time of diagnosis. Okay. So then if we look at clinical manifestations of type 2 diabetes symptoms tend to be more gradual. This is why screening for type 2 diabetes, especially in high-risk folks like people with familial tendencies or patients who are overweight or patients who maybe had gestational diabetes, is so important because they may be experiencing high blood glucose levels that can be damaging to the body, and they are completely unaware of it. Um, you guys will talk about incidence and prevalence a little more in your chronic course. And if you're interested, I think there's some discussion in your reading and also on the CDC website. But there are millions of Americans living with prediabetes or even with type 2 diabetes that are undiagnosed. And so screening, again, is really important here. Patients with type 2 diabetes will experience polyuria. They also experience polydipsia, although this is often overlooked. These patients kind of sometimes ignore the symptoms or don't really notice it. Type 2 diabetes patients don't tend to get the excessive polyphagia that we see in DM1. Um, there may be a little increase in hunger, maybe a little bit of weight gain, but it's not so like kind of significant as we see in type 1 patients. As opposed to the weight loss that we see in type 1 diabetes, these type 1 patients usually start as normal weight and then tend to get smaller. Obesity is more associated with type 2 diabetes. There might be some weight loss that they experience, but they may also experience weight gain, especially if there's increased hunger associated with this. These patients also experience blurred vision and fatigue, increased thirst and dry mouth, chronic skin infections, slow healing, and wounds. Chronic skin infections and this slow healing might be one of the first signs and symptoms that even alerts someone that they are experiencing type 2 diabetes. Other things in type 2 diabetes, frequent vaginal or urinary infections may also occur. Erectile dysfunction can be relatively common in men. They may develop neuropathies or numbness and tingling to their feet and their hands. We'll talk more about that piece and some of the micro and macrovascular complications. Okay. So treatment, our overall goals of treatment for both type 1 and type 2 diabetics is to attain normal blood glucose levels and keep them in a good tight control and to prevent any complications of elevated blood glucose. So we can do that through nutrition and exercise. These are things that we particularly focus on, nutrition and exercise for patients with type 2 diabetes, especially those who might be in that pre-diabetic window. And then we use anti-diabetic agents. So we'll talk about a few of those. Again, type 1 diabetics require insulin. There's no getting around that piece. They have to take insulin to survive. Type 2 patients, we might start out with things like weight loss or dietary management with really careful follow-up to see how they're responding to those lifestyle modification pieces. If they don't respond enough to lifestyle modifications, then we may move to anti-diabetic agents. We usually start with oral medications. And then if that doesn't control enough, we might move to like a GLP-1 medication. And if we still aren't attaining good control, we would move to maybe insulin. You guys will talk about the pharmacological management of diabetes at length in your pharmacology class, so I'm not going to go any further into it here. Okay, so we're going to talk about the acute complication of diabetes mellitus that we see in type 1 diabetics called diabetic ketoacidosis, otherwise known as DKA. So again, we really just see this in type 1 diabetics, and the reason for that is because they have that complete absence of insulin. This problem, DKA, at its core is truly caused by an absence of insulin. Okay. So without insulin, we get an increase in the release of fatty acids from adipose tissue and their subsequent release of ketones from the liver. Okay. Um, Sometimes we see DKA occur at the onset of the disease. So a lot of the time, well, not a lot of the time, but sometimes when patients are initially diagnosed with type 1 diabetes, it's because they come in with DKA. But DKA can truly happen at any point in diabetes, especially if someone is not managing their diabetes well. Or oftentimes what we see is that DKA is preceded by some sort of physical or emotional stress. So we have some increased stress response of the body. We need more, glucose production during that time, but we're not able to do it without the presence of insulin. So we achieve that increase in energy by breaking down fats into their fatty acids. Okay. Um, Things that we see in DKA, one is hyperglycemia. So blood sugar levels are high because of the absence of insulin. We see ketosis, and the ketosis is coming from the absence of insulin, causing us to break down adipose tissue into fatty acids with the release of ketones. And we see what we call metabolic acidosis. Ketone bodies are acidic, and their release into the bloodstream drops our patient's pH. When the pH of the body drops, we call that metabolic acidosis. Low pH is something that needs to be corrected quickly. Your body is very sensitive to changes in pH. And so metabolic acidosis is a byproduct of DKA that can have serious and significant consequences for your patient if not corrected. Okay. It can cause things like CNS depression. It can cause your patient to go into a coma. We'll talk more about metabolic acidosis when we get into our unit on fluid balance, electrolytes, and acid-base balance. Okay. Hyperglycemia also, of course, occurs here. And so now we've got elevated levels of glucose in the blood that causes that pull of fluid into the serum itself. And so now we've got diuresis at the level of kidneys. So we're losing a large amount of water. We're losing a large amount of electrolytes through the urine. Okay. These patients become dehydrated, and they can eventually have circulatory failure and collapse from that large volume loss. Okay. Right. Typically, when we think about how severe DKA is, it's usually related to this piece here, the severity of the acidosis. So the more acidotic my patient becomes, the more their pH drops, the more severe I would consider this episode of DKA. Okay. So now let's look at the clinical manifestations associated with DKA. So usually we look at this as a day or more of both polyuria and polydipsia. They also frequently experience nausea, vomiting, and fatigue. If that is uncorrected, eventually as their pH drops, it can progress to stupor or coma. Okay. They experience abdominal pain and tenderness. Because of the hyperglycemia, there's often a fruity quality to their breath. Because they're losing a lot of fluid through diuresis, they become hypotensive. And because of that fluid loss, their body compensates by increasing the heart rate, so they'll become tachycardic. Their breathing increases, as does the depth of respirations. We call this Kussmaul's respirations. These are directly related to the response to metabolic acidosis. So again, frequent urination, extreme thirst, they'll have high blood sugar levels. They'll have ketones as well in their urine. So if we test their urine, there will be ketosis, nausea and vomiting, abdominal pain. They may become confused. Their respiratory rate goes up and they're fatigued. Breath is fruity, they're flushed, and their mouth and skin are quite dry. So that's what a diabetic ketoacidotic patient looks like. Okay. So treatment of DKA, these are kind of the three big hallmarks of treatment of DKA: giving IV fluid, administering insulin, usually via IV drip, and monitoring and correcting potassium levels. Okay. So we have to treat that significant and severe volume depletion that we see because of that hyperosmolar fluid loss via the kidneys. So we might give 2 to 3 liters of fluid initially relatively quickly over the first 3 hours, and then start to draw back on that as we start to correct that blood volume. let's see. We also want to bring our blood glucose level down. So we're going to start an insulin drip to bring those levels down. You'll notice in my IV fluids that I note that we add glucose to that IV fluid. It might be counterintuitive to think about, well, why would I add glucose to my IV fluid when my overall goal is to bring my sugar down? Well, part of that is when your blood glucose level drops below 250 is the point where you would do that. What you don't want is someone's blood glucose level to drop so much that you can't continue the insulin drip. Remember, we said that DKA at its core is a deficiency of insulin. And so you want to maintain an infusion of insulin. And if we don't add that blood glucose, or excuse me, that glucose to our IV fluids, and we allow our glucose to keep dropping and dropping and dropping, we'd have to shut off our insulin drip. And we don't want to do that. So to prevent having to stop insulin, we add a little glucose to our IV fluids while we're correcting volume depletion so that we can maintain the infusion of that insulin drip. Okay. We also want to make sure we're maintaining electrolyte imbalances. So if our potassium gets really, really low, we may have to hold the infusion of insulin for a time while we correct that. One thing to understand about insulin is that it facilitates the movement of blood glucose into the cells, but it also facilitates the movement of potassium into the cell. And so if we're giving a lot of insulin, we're also pushing more potassium into the cell and out of the serum. And so people's serum potassium levels start to drop. And so if we start to drop our potassium levels into more kind of danger zone levels, we may have to temporarily stop or slow our insulin while we correct that. Okay. We often give maybe some potassium even in our IV fluids as well, along with our glucose, just to keep that potassium level maintained while we're giving while we're giving insulin. So that's what we talk about when we talk about electrolyte imbalances. We also have to work to correct the acidosis. I'm not going to talk too much about that now or the potassium piece because we'll talk more about that and its relation to DKA when we get to the fluid and electrolyte piece. Okay. Well, now we're going to talk about another acute complication of diabetes that we see in type 2 diabetic patients, which is hyperosmolar hyperglycemic state. Okay. This is a patient who has high blood sugars, hyperglycemia, hyperosmolarity, meaning that they're pulling fluid into the vasculature because of the high blood sugars, and they're dehydrated. So all of those things were stuff we saw in DKA. The big difference here is these patients do not develop these patients don't develop that ketoacidosis piece. So HHS, hyperosmolar hyperglycemia, and DKA are very similar. We just don't see the ketoacidosis part in HHS. Again, this is typical of type 2 diabetes, and the reason we don't see ketoacidosis is because type 2 diabetic patients still produce some level of insulin. They don't have that complete absence of insulin that we see in patients in DKA, so they instead develop HHS. Okay. One thing we do see in HHS compared to DKA, though, is often a more even severe volume loss because they often have renal impairment in conjunction with this hyperosmolar state. So we see even more significant volume depletion in HHS. So some common signs and symptoms here: weakness, dehydration, polyuria, thirst, and a lot of neurological alterations. Sometimes these neurological alterations can look like stroke too, so we do have to be careful to distinguish between the two. We can see things like hemiparesis, meaning one-sided, unilateral weakness. These patients can even experience seizures or comas, again, so they can be often mistaken for signs and symptoms of stroke. Okay. So we see also elevated blood glucose levels, often above 600 milligrams per deciliter. They're dry, they're thirsty, they're going to the bathroom a lot. Their skin might be warm, they might experience fever, they're sleepy or confused. They might have trouble with their vision. They might have hallucinations. All of those are some manifestations of HHS. Okay. So treatment of HHS involves monitoring and correcting the overwhelming dehydration. We also have to correct the hyperglycemia and also watch these patients for electrolyte imbalances. Um, we need to watch these patients really closely too, because as we start to correct the hyperglycemia, water can start to move pretty quickly back into the cells from the serum. And so these patients are at risk for potentially developing cerebral edema. So we watch their neurological status very closely to monitor for that potential complication. Okay, the next acute complication we will talk about with diabetes is the acute complication of hypoglycemia. Really important for you guys to understand and be able to distinguish the signs and symptoms involved in hypoglycemia. This is one of the most common thing that when we talk to like nurses who've been working a while or nurse managers, this is one of the things that often they report new nurses missing. They're missing the signs and symptoms of hypoglycemia. So I really want to emphasize the importance of you understanding what these look like and really knowing kind of what you're going to do about it if you were to assess this in your patient. So definition-wise, it's a blood glucose less than 70, either with or without symptoms. Anytime we have a blood glucose less than 70, even if our patient is asymptomatic, we're probably going to want to consider whether we want to do something about that. And sometimes there's some patients who have blood sugars that drop quite low and don't really have any symptoms at all. Those are the patients that sometimes are quite concerning too, because they can have significant blood glucose drops without signs and symptoms until they're really in trouble. Sometimes when I would take care of diabetic patients, I would often ask them that question. I might say something to them like, do you know when your blood glucose drops? Do you have symptoms of that? Just to kind of get a gauge of if what they knew what those symptoms were and if they even experienced them. So something to kind of think about there as far as those numbers and symptomatology. Just because there are no symptoms doesn't mean their blood sugars aren't too low. Usually the most common cause of hypoglycemia is the administration of insulin. It can be caused by some oral anti-diabetic agents. You guys will go into that again in your pharmacology course so that you're able to distinguish which may cause it and which don't. So I'm not going to go too much into it here, but really the most common cause is insulin administration, either in incorrect timing. You guys will talk more about this again in pharmacology, and you'll do some individual work on this as well in your 2015 glucose management lab. So things like incorrect dosing of insulin, failure of someone to eat, especially around times of insulin administration, excessive exercise, the removal of a stressor can also cause hypoglycemia, changes to people's medications. Other things, changes to injection sites. Patients develop scar tissue if they're injecting kind of in the same place in their body all the time. And so if they change injection sites, the insulin might be more readily absorbed than it had been. There's also variation in the speed and amount of insulin absorbed depending on sites. So sometimes if we change injection sites, we might absorb more insulin than we're used to, and we might see hypoglycemia. So the symptoms that we see in this are directly related to the lack of glucose to the brain and the activation of the autonomic nervous system. So remember that the brain has to have glucose for its functioning. We can break down things like fatty acids that supply fuel to other cells in the body, but the brain has to have glucose. So many of the symptoms that we see are neurologically related because the brain is starting to run out of fuel pretty quickly, right? And we also see activation of the autonomic nervous system. Remember, one of the counter-regulatory processes to low blood sugar was the activation of the sympathetic nervous system. And so things like the release of epinephrine counteract the action of insulin because they can bring up blood sugar levels. So a lot of the signs and symptoms are going to look like that fight or flight response because we're activating that autonomic nervous system. But again, symptoms can be really variable, especially in children and in older adults. Some people are completely unaware of hypoglycemia. So really good assessment is paramount here so that you know what your patient experiences with hypoglycemia or if they've ever experienced it before. Okay. So treatment is immediate administration of glucose. Okay, so you have to give someone glucose in some fashion. We're going to talk about that more in a moment. If you have a patient who can't swallow, maybe they have lost consciousness because of the extreme nature of their blood glucose drop, in those patients, we can give injections of glucagon. So if we can't give blood glucose orally, we're going to give an injection of glucagon to bring blood glucose up. Okay. So this little graphic will give you a little more information about what we kind of talked about, right? But hypoglycemia, low blood sugar, less than 60, usually caused by too much insulin or too much diabetic medication. It can also be caused by some other things like not eating enough, exercising too much, medications, whatever it might be. So low blood sugar, here are your causes. Your patient will have symptoms like hunger, fatigue. They might be shaking or tremoring. They're sweating. Their skin becomes pale. Headache is pretty common, as is dizziness. Okay. A lot of these, again, are autonomic nervous system kind of things that we often see with sympathetic stimulation. As the brain loses glucose as fuel, these patients can become confused. Their speech may become slurred and their vision becomes blurred. One thing I'll say too about low blood sugars, sometimes these signs and symptoms can be mistaken for stroke. So one of the things that we do when patients are coming in, maybe through an emergency department, if they're experiencing stroke-like symptoms of slurred speech and confusion and blurred vision, we also check their blood glucose levels. Because if they're low, we would give glucose, and if those signs disappear, guess what? Not a stroke, right? If blood sugars aren't corrected, our patients may faint, they may go into coma, they may experience seizure activity. Okay. So the treatment, let's test their blood sugar. Let's see how low that is, right? And then we give glucose. They can either eat or drink glucose. Typically, we start with about 15 grams of glucose, either from food or from fluid. Wait 15 minutes, test them again. If they're normal, we're good. If they're not normal, we might give another 15 grams of carbohydrates. Okay. If they're unable to take in any glucose, we give a glucagon injection. Okay. Either in the thigh or in the buttocks, but we give glucagon. So the next complication we're going to talk about is related to some of the actions of those counter-regulatory mechanisms we talked about earlier. Specifically, we're going to talk first about the Somogyi effect. So in the Somogyi effect, we have a diabetic patient who's probably taking certain doses of insulin during the day, and this is causing them to have a hypoglycemic episode sometime during the night. So here's my patient, and sometime at night their blood sugar dropped below 70 degrees. So they had, or 70 milligrams per deciliter. So they had an incident of low blood sugar overnight, probably while they were sleeping. And this low blood sugar activated the release of all of those counter-regulatory hormones that we talked about earlier. So they had a release of maybe epinephrine and growth hormone and cortisol and glucagon, and all those counter-regulatory mechanisms seek to increase the levels of circulating glucose. Okay, so those things are being released in reaction to that hypoglycemia in an attempt to counteract it. So we get increased glucose production at night. Okay, and so then in the morning, when this patient wakes up and we test their blood sugar, they have a really high blood sugar number. Okay. And so clinically, sometimes we look at this and think, man, we've got a patient with these really high blood sugar levels. Maybe I should go ahead and start increasing the amount of insulin they're taking because clearly their blood sugars are too high. But the true nature of this, or the root of it, was some sort of hypoglycemic episode at night. And so if I react to those clinical high blood sugar numbers by increasing their insulin administration, I'm going to actually make this effect worse because I'm going to cause more hypoglycemia at night. I can actually cause significant issues for my patient too if I make this hypoglycemia at night so severe that their counter-regulatory mechanisms can't counteract it. We could have a patient with severe hypoglycemia while sleeping. Neither of those things are things that we want. And so if I have a patient experiencing Somogyi effect, I need to know that that's the cause of it so that I don't increase their insulin, right? And so what do I do about this? Well, I may need to, if I'm assessing high blood sugars in the morning, I may need to go ahead and wake this patient up, maybe in the middle of the night, and check their blood sugars to see if they're dropping at night to determine whether it's a Somogyi effect. So again, the Somogyi effect is when hypoglycemic period happens during the night, causing rebound hyperglycemia caused by the release of all these counter-regulatory hormones. The Somogyi effect is more common with type 1 diabetes. And what we probably need to do is adjust insulin administration timing and dosaging to prevent these drops of blood glucose at night. Okay. And we can compare the Somogyi effect to another thing that we see in the morning with elevated blood glucose, which is called the dawn phenomenon. Um, in the dawn phenomenon, we also see increased blood glucose levels in the morning, but they're not being triggered by those counter-regulatory mechanisms in response to hypoglycemic events at night. So this patient with the dawn phenomenon of increased blood sugar in the morning isn't having some big drop in their blood sugar at night. Their blood sugar is stable. Maybe it goes to about 80 and slowly rises, but by the morning they have this big spike in their blood glucose level. Okay. We see this because of, remember when we talked about the release of cortisol or those stress hormones, and then we talked about them having diurnal variation. And remember we said that cortisol has its highest level of secretion really early in the morning, usually between 4 to 6 a.m. These are those diurnal or circadian variations that we see in hormone production, okay? So we see increased cortisol release early in the morning, but we also see an increase in glucagon release early in the morning. And this stuff kind of makes sense for a normal person, right? If we're getting ready to wake up, an increase in blood glucose levels, stimulates us, hey, we've got this extra energy. It stimulates you to wake up in the morning and have the energy you need to kind of get up and get out of bed. So there's a reason that this happens. But in the case of a diabetic patient, all of that counter-regulatory release is going to cause them to have these blood sugar spikes in the morning, okay? This phenomenon is very common, especially in type 2 diabetics, okay? So growth hormone released during the night, glucagon released during the night, cortisol released during the night causes this increase in blood sugar levels that we see in the morning, okay? No hypoglycemic episode at night. So for these patients, it may make sense to increase the amount of insulin that they have, especially maybe long-acting insulins or insulins that might work overnight so that they don't wake up with these increases in their blood sugar levels. Okay. Okay, the final thing we're going to talk about are the chronic complications of diabetes. And both type 1 and type 2 diabetes can cause a significant amount of complications throughout the body for patients. And this is why it's of paramount importance to maintain really good tight blood sugar control for diabetic patients. Because if our blood sugars are often out of control, it can increase the incidence and severity of all of these complications. So we break them into kind of two categories, microvascular complications and macrovascular complications. So we'll start with microvascular complications. And so these are things like neuropathies. Neuropathies are abnormal sensory and motor function pieces. So we may have numbness or tingling to the extremities caused by damage to the nerve fibers to the extremities themselves. Okay. We also see nephropathies. Nephropathies happen within the kidney. So we might see glomerulosclerosis. So that's changes to the tissue itself within the glomeruli. And this can lead to chronic kidney disease. Diabetes is one of the most common causes of chronic kidney disease in the United States. Okay. We also see retinopathies, and that's changes to the eyes. So these patients may develop cataracts, they may develop glaucoma, they're more likely to develop things like retinal detachments. Okay. They also have a lot of damage to the endothelial tissue in general. So we see a lot of damage again to any endothelial tissue throughout the body. Okay. We also have macrovascular complications, coronary artery disease, cerebral vascular disease, and peripheral vascular disease. Okay. So these patients can get cerebral vascular infarcts, they get ischemic heart disease or heart attacks, and they develop atherosclerotic changes to the vasculature in the legs that can cause peripheral vascular disease. We're going to talk more about the reasons why and the end results of all of these pieces later on when we get to cardiac units and peripheral vascular units and neurological units. Another common complication of diabetes are diabetic foot ulcers. Those are a common problem in patients with diabetes. They often can become severe enough to cause deep ulcerations. These patients are more prone to infection, and so oftentimes those ulcers become severely infected. If those infections can't be cleared, it can lead to gangrene and ultimately the need for amputation in these patients. So when you're working with diabetic patients who have experienced amputation, that is the reason why. They had some sort of ulceration to their foot that developed an infection that we couldn't heal, and they end up with a amputation. Because these patients have neuropathies and altered sensation to their feet, they're more prone to developing ulcers because they don't necessarily protect the skin of their feet as well because they don't have that pain mechanism. And then they also have really poor blood circulation to their feet because of the changes to the peripheral vasculature. And so without good blood supply, if we develop an ulcer on the foot, they don't heal as readily. Those ulcerations tend to get deep. They don't heal. They get infections, gangrene, amputation. Okay. Again, these patients are also much more prone to infections in their soft tissue, so things like cellulitis, dental infections, so they need more frequent dental visits. They can be more prone to bone infections, so osteomyelitis. They get more UTIs, so genitourinary problems. These are all kind of things that just much more common in diabetic patients. So make sure you review all of those kind of chronic complications that we see with diabetes.